Middag allemaal, hoe gaat het? Honorables?
Kan ik klaar, Honorable Dr. Noma French?
Well, for Dr. Kluti, please.
I have, Minister.
Dr. Valabji is here. I'm trying to check who's from the team. Oh, okay. I think everyone is here.
All right, it's just gone 2 o'clock. So very warm welcome to you all to this Provincial Parliament Ad Hoc Committee on COVID-19. It is Wednesday, the 3rd of February. I'd like to welcome you all to this meeting that will be dealing primarily with vaccines. Let's start with some apologies. I have received apologies from Honourable Botha, from Honourable Syed, and from Honourable Christians. Are there any further apologies to be tabled at this stage? Honourable Heron?
Chairperson, yes, I will be leaving the meeting at 4:30.
Perfect. Thank you. We will make a note of that. Any other apologies? Okay. All right. If there are no further apologies, I'm just going to start with the rules of engagement for virtual meetings very quickly. Members are all muted and participants are muted to avoid background noises. Please flag any points of order by using the raise hand function or by using the chat box. We ask that video and audio be switched off unless you are speaking or participating in the meeting so that we can ensure a good quality of the connection. We ask that presenters will unshare their presentations when they have concluded their inputs. And then finally, the maintenance of order is found in the directives for sittings of the House and meetings of committees by electronic means, which was AT Friday the 17th of April of 2020. So today we're very happy to receive a general update from the Provincial Department of Health on the COVID-19 virus, how it's developing, as well as indicators in the Western Cape, and then importantly on vaccine planning. And so we'd like to welcome Minister of Health, Minister Mbombo, as well as Dr. Keith Kluti, who is the Head of Department for Health, as well as Dr. Krish Valabji, who is the Chief Director for the Strategic Cluster. We'll also be having a briefing from the Minister of Finance and Provincial Treasury on the funding for the vaccine. And so we welcome Minister Mania, Mr. Savage, the Head Official of the Provincial Treasury, as well as Dr. Roy Haberman, who's the DGG of Fiscal and Economic Services. How we will work the meeting today is we will have both presentations and we will have a maximum of 1 hour for both. So approximately 45 minutes for health and about 15 minutes for Treasury. We will then have 2 hours for Q&A for the members to engage with the various departments. So since our last meeting, quite a number of things have happened. We're certainly through the second peak. The adjusted level 3 regulations have been relaxed, and certainly this committee's focus is now firmly on vaccines. And also with the arrival this week of vaccines on South African shores, we await with great anticipation the details concerning the allocation to the Western Cape and to understand how vaccine rollout will work. This is, of course, a matter of great public importance because no one is safe until everyone is safe. So on that note, we'll start with the Department of Health. A very warm welcome to you all. Minister Mbombo, would you like to make some opening remarks?
Thank you, Chair. I'm not sure whether you can see me because I'm using another device.
Yes, we can.
Okay. Thank you for the opportunity. As you alluded to, that the focus will be on the 4 points related to the vaccine, which is the receipt of the vaccine in all phases, the numbers and types of the vaccines expected, the rollout planning of the vaccine, the possibility of the generic vaccine being developed. Dr. Kluti is going to do the presentation. I think he's going to run it through quite fast so that it will focus more on the vaccines. I think the others, in terms of where we are, is just going to have a brief kind of summary in regard to the decline of the cases. But before he presents, just maybe 4 things, Chair, and also honorable members, is to understand that we are currently following a national program in regard to the acquisition of the vaccines, the procurement of the vaccines, and also in regard to the rollout in terms of the prioritization, which is similar with the WHO. So with the vaccines that are now, that we'll be talking about, it's a 1 million, which already arrived, and also the 500,000 that's supposed to arrive probably in early March, which is part of the 1.5 million that the National Department of Health and Treasury bought from the Serum Institute of India, which is the Covishield, better known as by their developers, AstraZeneca, and also Oxford University. So these are the vaccines that we'll be talking about as the phase 1. In the phase 1 is the healthcare workers. The healthcare workers are also divided accordingly, which is those in the public and also those in the private, because with the COVID, that's where we've been working throughout. You cannot separate. There are also those in the public. There are those who are on PESAL, which is employed by the provinces, which is the one that we will be expecting that 35,000 that will be coming. And then there are those who are not on PESAL, but they are working in the Department of Health, which is the community health workers. They also form part of the healthcare workers of the public. And also there are those who are appointed by the city, which are not on PESAL, but they are also added. And the other categories is the students, which you'll find that they form part of the other category, because the reason for this is about not only, if you recall, that the department, for those who are for the whole of South Africa, for those who are insured on medical aid, they will be charged directly from their medical aid, which is the process that is happening there at the national level. And they'll be charged double, so that with the other one, it also assists for another person later on. That is not within us, it's within their scope. So you also have the community, as I indicated, community health workers, the care workers, the traditional health practitioners, and also the students. With the 1.5 that is in total, we have to provide, it has been confirmed in terms of the national program, that we have to give 2 doses as according to requirements and also according to the interval. Therefore, it confirms that for the total doses for the whole of South Africa, it's going to be about 702. It's supposed to be half of that, but I think we will have to take into consideration some of those that still have to go for testing in terms of the sampling. So around about 702, that inclusive of the public and the private. So that is the total of number of the healthcare workers in South Africa that will get the 1.5, both the first and the second doses. So for the Western Cape, although we would have worked out around about 133 for first doses, and then you double that for becomes 260 something. Of course, common sense is what chances that we get 266 doses out of 702. So therefore, that's why it's crucial to understand there is a need not only for contingency plan from our side, but also the confirmation from the national that there are other upcoming doses that are coming up. You'll see when the HOD is presenting. So NP, we are following the national program that the HOD is presenting. But there are other responsibilities for the provinces in regard to not only submission of who are these healthcare workers, plus also identifying the sites, 370 plus sites, the training, which I'm part of the training out of those 1,990 something healthcare workers that have undergone training, still undergoing training. I'm part of that because it is crucial so that you could be able to master it in regards to the training. And also take into consideration with the traditional health practitioners, with the students, with the care workers specifically, you'll find that there's a lot of the communication that is supposed to go there, which is I've already started with the traditional health practitioners in regards to the safety and also how does it work. Whilst within our own system, our staff and private and the public who are health professionals, there are always some scientific information that is being passed through. And then lastly, Chair, we need to understand that the vaccine is not protecting you in totality that you won't be able to be infected, but it reduces the chance and the risk of you ending up with a severe disease and also death. It also reduces the chance of transmitting to the other. So that's, and also it protects the health system. When we've got fewer people who are infected, it means that at least the health system will still be stronger. However, we need to understand that the issue of the non-pharmaceutical interventions will always remain there. And therefore, that's why we urge everyone, including honorables, as they are as constituency head, MPs and PLs and all of them, especially now that we have opened, the restrictions now have been reduced. The issue of the gatherings, the churches, the restaurants, for us, we won't be able to go there and preach the gospel of the NPIs. So we rely on the other systems or other sectors and the communities to stick to the health regulations, health protocols, and also the regulations, and also for everyone to take responsibility, because vaccination is part of the whole of the COVID response. We may talk about the vaccines, but what matters most is the vaccination. It's the vaccination that will that is matters, which you'll see when the HOG presents that actually that's where the costs are. Vaccine might be cheaper, but the cost of the vaccination, inclusive of other costs that are unforeseen or expected overheads related to having all the ancillaries and the consumables, and also taking consideration that we are taking money that was not there. It's not that there's been additional money. It means that within our own budget, we have to rob Paul and pay Pauline. Thank you, Chair. Over to Dr. Casey.
Thank you, Minister. Thank you, Chairperson. Can I just check with you, are the slides visible?
Yes, they are. Thank you. Warm welcome to you, Dr. Cloete.
Thank you very much, Member Wenger. As indicated to you, these are updated slides. So the slides that were sent to you about 4 or 5 days ago just shows how things move. They're all outdated, and therefore these are the updated information. So as the Minister said, I will give a very quick update on the surveillance response, where we are, the health platform response, and then the healthcare workers in terms of COVID. But the biggest focus will be on the vaccine strategy, and we'll spend a little bit more time on those. But just on the surveillance update, we've previously shared with this committee this graphic. And what we can now clearly state and see is the full extent of us coming out of a second wave, which were significantly more, at greater impact than the first wave. So the lines, as previously described to you, the green line is the oxygen use, the daily oxygen use. You can see that is declining. The blue line is the hospitalization, that's declining. The solid red line is the deaths by date of death, not by reporting day. And the dotted line is what we call the officially reported deaths. And then the test positivity is the yellow line, which shows you the proportion of the tests that we sent to the laboratory that is positive. All of those are showing a decline as we come out of the second wave. Just in terms of hospitalization, the solid green line is the public sector, the dotted green line is private sector, both is on the decline. In terms of mortality by date, I think previously we've had quite an extensive discussion at this committee on this issue. Just to show you, as I said, the dotted line is what we officially report. The red line is what we adjust on the reported deaths, and the green line is what we get from the MRC's excess death report. So you can see that we've tried to align all of these. So just on this graphic, the dotted line, we are at 10,378 as of yesterday deaths, but the red line is at 11,500 because that is the additional data we're getting from the Home Affairs. And what the what the MRC is reporting officially is 13,000 deaths so far. So you can see there's a gap on the first wave, and there's a gap on the second wave. But it's in terms of how close we are to the MRC, this is much closer than we've been in the first wave. The reproduction number, we previously explained that number. That is how many people that is infected affect other people. So it's currently 0.5. That's why we are declining so sharply. It basically means for every 2 people that's positive, only 1 additional person gets infected. And that's a sharp decline of where we find ourselves everywhere in the province. This is the picture of the provincial picture. You can see week on week, we've had a 44% decrease on cases, and admissions have dropped by 42% and deaths by 31% respectively. The test positivity rate is now 13.47, where at the peak it was 50%. All of this is pointing down. Active cases, you can see the metro versus the other districts all coming down. And in the metro, the sub-districts, you can see the difference between Khayelitsha being the lowest for the second wave, and you can see Southern being the highest for the second wave, and the comparative figures for the first wave. This is the metro picture, a decline in all the areas. And this is the rural picture, a decline in all the areas. Where Garden Route declined first, you can see a decline everywhere. West Coast, Overberg, Cape Winelands, and Central Karoo. The wastewater is quite an important one for us for surveillance. You can see all of those. All the treatment plants in the metro have shown a decline in the number of detecting COVID in the wastewater. The only exception is called the Westville Industrial Area. We have to kind of look into that. And if we look at the outside the metro, we're doing this in Breede Valley and Overberg as well. In Rawsonville, there's still a little bit of lagging COVID in the wastewater. But quite interesting, if you go to Theewaterskloof, it's all dropped. And actually a place like Caledon, there were no COVID detected in the wastewater. So this system will be of great value if we drop right down, and then to help us to detect any early increases in COVID in wastewater. This is the Garden Route, also come down completely in terms of all the markers. The health platform, last time we were here, we were talking to you about the hospital admissions and the peak, and what does that mean? It's come down everywhere, and our acute hospital platform, as of yesterday, we only had 2,300 COVID patients in acute hospitals, 1,300 in the public sector, just over 900 in the private sector. The hospitalizations have declined. Trauma cases has remained significantly low, and that's been linked to the restrictions on alcohol. The metro hospitals running currently at an average of 79%, and in all the other areas, but for COVID, it's about 38%. So you can see there's been a significant decrease in COVID cases compared to other cases. And the total currently make up 18% of all cases are COVID, whereas at the peak, we were at about 35%. Sorry about that. And then just to make the point here that the Hospital of Hope in Brackengate is currently running at 82 patients, which at the peak, it was running at 300 patients. Mitchells Plain Hospital of Hope, which is the 200-bed hospital that we opened on the 1st of January, is now running at 61 patients. Solstraal at 48. And then the Metro Fatality Center has 24 bodies currently in that center. So this is the picture. You can see a completely different picture from when we were the last time. The average bed occupancy is 74% for all cases. But for COVID, you can see it is 39%, and it's in the low 30s. And the total number, or the total proportion of all cases in hospital beds as of 1 o'clock yesterday is 18% as opposed to 35%. This is the daily oxygen use. We also, the last time, spoke to you about oxygen. And you can see that the purple line is what the public sector hospitals, so it's Western Cape government hospitals use. The green line is the total. And obviously the balance is what the private sector use. So you could see that for us as a public sector, the purple line, we just peaked over about 50 tons a day, which is extremely high, but we're currently down to about 32 tons a day. Whereas the total peaked quite significantly above 80 tons a day, whereas the production capacity in the province of Afrox is only 70 tons a day. That's why for this entire period, additional oxygen had to be trucked in from neighboring provinces to help with the oxygen supply. But we have now established that we have our daily use of oxygen is now dropped below 70 tons a day. So it's now less than the production capacity that's present in this province. This is our public sector. We ran about 12 tons a day before COVID. At the peak in the first one, we used 27 tons a day. And as I just said to you now, we peaked at about 52 tons a day, and we're down to about 32 tons a day. And that's the use just for public sector hospitals. So this is the summary that I just spoke to you now. We're glad to say that our current total use is less than the 70 tons that's being produced in the province, and our situation has stabilized. Our healthcare workers, just to tell you this picture, healthcare workers, 8,689 have become infected with COVID to date. That's out of 35,000 people. That's almost a quarter of our people that have become infected. You can see the first wave, and then you can see this very, very steep peak in December for the second peak. At the last time I think we were with you, we were at over 1,000 people active. It's now dropped to 257 as of this morning, and we've had 114 deaths so far. That 257 that's currently active is 29 doctors, 190 nurses, and it is significantly dropped in all the categories across the province. The 114 deaths could tell you the very sad picture of that 46 of those deaths happened in December, whereas in January we're back to 7 deaths. This 46 death has caused untold psychological and mental trauma amongst healthcare workers, because this coincided with also a peak in deaths in the general population. So people were personally affected by the second wave, and December has been really a bleak month in terms of the impact of COVID on everyone. So we started this process of intentional grieving and healing with our healthcare workers, because we want to actually deal with the trauma and open the space so that we can have a real healing process in that with them. The recruitment drive, we also last time spoke to you, we've actually recruited 903 additional staff members in this period of time. You can see the breakdown of the 903. Majority is nurses. We employed an additional 650 nurses during this period. So to come to vaccines. So I'm just going to put this up for you and take a little bit slower. So the prevention of the aims of the vaccine program in South Africa is to prevent severe illness and deaths. You just saw the devastation of severe illness and death in terms of people being hospitalized and how many people die. So one of the important things of the vaccines is that we want to prevent that severe illness and death repeating itself repeatedly. The second one, which is probably one of the important reasons why we're doing the vaccinations, is to stop transmission altogether. And that is where the term herd immunity comes from. Because if more than 70% to 80% of everyone, the whole population, is immunized, you can stop transmission altogether, which allows you to get to some form of returning to normality for all activities of society. So the bigger aim is to get to herd immunity and reducing transmission of the virus. But at the same time, we also want to protect the healthcare system, because that is, you can see the impact that the healthcare system has taken and healthcare workers themselves have taken. So it's on the basis of this that the WHO has recommended that when you do this and you phase your implementation, you start with healthcare workers, then you go to your vulnerable groups, then you go to the broader population. And you'll see later on that we've actually adopted that convention in South Africa, and that's the program that we're busy presiding over. As of the 1st of February, 2 days ago, 98.3 million vaccines of COVID has already been given. 31.8, so a third of those vaccines have been done in the USA. The Bloomberg.com is a very useful one because it's called the vaccine tracker distribution, and it updates daily to tell you how many people have been vaccinated across the world. This is a very important slide, just to give you a sense of the vaccines that we're talking about. So I'm going to go quickly through these vaccines and just explain to you what we mean. And this is vaccines with what is called available efficacy results. So this is, if you look at the right-hand column, it is when the results of the trials have been published in peer-reviewed journals. It's a scientific information so that your regulatory authorities can look at this and make informed decisions about whether to register that vaccine for use in any specific country, because that is then the scientific basis on which you say it's safe to use the vaccine. So the three with really clearly published information to date is the Pfizer vaccine, the Moderna vaccine, and then the vaccine called that was an Oxford or AstraZeneca. And I'll come a little bit later to it, the one that we have received our first doses of, which is then the Provincial vaccine, which is based on this Oxford AstraZeneca vaccine. So the efficacy means how many cases are you averting by having the vaccine taken in a group. So you see, Pfizer's got quite high efficacy, and AstraZeneca, the Provincial AstraZeneca it's got a range of efficacies, and this is due to different contexts where these efficacies were tested. But the big important thing is efficacy against severe disease. That means if you take the vaccine, that you are protected against severe. And you can see all three of these vaccines has got very high efficacy. In addition to the ones that there is still information that needs to be shared, like Sinopharm from China, Sinovac, and then Sputnik, which is the Russian vaccine, Novavax, which has been released last week, and then Johnson & Johnson, which is the one I'll also come back to. The big difference between all these and Johnson & Johnson vaccine, when we have all the information, is a one-dose vaccine. It doesn't require 2 doses. And the big difference between Johnson & Johnson and all the others is that Aspen, which is a local manufacturer, has got the rights to produce Johnson & Johnson in this country, and that will happen in PE. So there's one big difference between Johnson & Johnson, it's the single dose, but also the fact that we will have a local manufacturer, one in the country that will actually manufacture. All these other vaccines are manufactured by manufacturers overseas. So the information we then have about these 3 vaccines, and I'll come back to that these are currently the 3 that we're working with in terms of getting in the country. So then a big question is, how does this vaccines work? So I just took a snippet out of just explaining how 2 of these types of vaccines, how these 3 that we're going to work with work. So the AstraZeneca vaccine, the one that we have got in the country now, it is done by what is called a viral vector vaccine. So both the AstraZeneca vaccine, the Johnson & Johnson vaccine, which will become available later, and the Sputnik 5 one, the one from Russia, use the same technology. I'll just explain to you on the left-hand side, this is the SARS virus. In the SARS virus is that black thing there. That is what is called the spike protein. So what the vaccine process does, the scientific process, you can see a little scissor there, is actually cut out that spike protein. So you can take a snippet of that out of the virus. And that spike protein is the one that you want a response to. What they then do is they take a harmless virus, and that's what is called a viral vector. The vector in this case is a virus called the adenovirus. This is a virus that normally gives us common flu, but it gives you symptoms, runny nose, a little bit of a cough, a little bit of a throat scratch, but it's only about 3-4 days. It's your common cold and the very mild version of it. Now, because that's such a harmless virus, adenovirus, they then take this protein and insert it into that. And therefore, when this adenovirus comes into your system, it carries the spike protein that is from the COVID virus. So it's not the COVID virus; it's the adenovirus that's carrying just the spike protein in its makeup. That gets immunized. You get given an injection. It comes into your human cells, and in your human cells, it then gives rise to that the spike protein go onto the cell, and it stimulates an antibody response, and that's how the vaccine works. Your body mounts an immune response to the protein that's been put in a harmless virus, and therefore you got the immune response, and therefore you become immunized or resistant to the various forms of the COVID disease. The next one is called the the mRNA vaccine, and that is the Pfizer and Moderna. Those are the two that was first registered. Again, they take the spike protein, but in this case, what they did with the spike protein, they use that to make what is called a synthetic RNA code. So it's almost like taking the spike protein and do what would be a RNA code. So it's like they take the sequences and create a synthetic version of the RNA. That then gets packaged in what is called lipid nanoparticles. So it gets put in these, and that is what goes into the vaccine. So again, it gets injected, it goes into the human cell, and because the synthetic RNA, it's a replica of what was this spike protein. It comes there, it gets read in the same way as the spike protein, and it then mounts an immune response, again, antibodies, and that's where the immunity comes from. So that is how this works. The cell to the bottom here, that's what we call the nucleus of any human cell. That's where your DNA sits. So you can see this thing bypasses the DNA completely. So somewhere along in the fake news world, people said these things come in here and it alters your DNA and all of that. So it completely doesn't touch the nucleus of the cells in any way. So it's have absolutely no influence on the DNA of the human cell. So then the big question is, was the vaccine development rushed? Now, when people hear that the vaccine is developed under 1 year, obviously there are concerns. And normally vaccines take something like 10, 15 years to develop. How can we trust the vaccine that was done within a year? It must have been rushed, so there must have been something wrong with it. But this is the scientific answer to that. The Chinese scientists made the genome or the genetic material of the virus available globally in January this year. So multiple organizations and the researchers could use that genetic material and they could start developing vaccine at the same time. That is unheard of previously. People had to harvest it. Now that in itself, just getting the genetic material, putting it together, already takes about 2-3 years. In this case, 2-3 months after the Wuhan outbreak, this genetic material was made available to everybody to start the vaccine. The second thing is what normally happens is you hear phase 1, phase 2, phase 3. What happened is a lot of these clinical trials, the phases were combined so that the vaccines could progress more quickly through what we call the clinical development process. But nowhere in the fact that you combine these phases have they compromised on the safety aspects. The safety aspects is identical to what has always been there. It is just that the phases start running concurrently, not one after the other. They start running concurrently. Then the third factor is probably the most important one, an incredible amount of resources and funding, and incredible amount of scientists were dedicated to this. So the scientific task took much quicker than normally would be the case. And then because the disease itself was so prevalent and so present everywhere, it's also very unheard of that the entity that you require to be able to do your trials was virtually everywhere, and there were large volumes of cases. It could be tested in a much shorter period of time. And also what people did is they built on the previous efforts of trying to develop vaccines for the previous, let's call it, risks of pandemics, which were SARS and MERS. And because both of those were coronaviruses, a lot of groundwork has been done to be able to facilitate this process. So all of these things come together, means that the vaccines were developed in a record speed, but none of the normal rigor was neglected in this process. So will the vaccine work against the variant, which is called 501b2? The scientists are all hopeful because the vaccine targets the entire spike protein, not just parts. You must understand in the variant, the mutation was only on parts of the protein, not the entire protein. And a definitive answer in South Africa will be there in mid to late February because there's a South African trial looking at specifically this. But the laboratory studies are also on the way. Worst case scenario, the vaccines just need to be tweaked and modified like the flu vaccine. But it's in all likelihood, there's no evidence to suggest that the vaccines that we currently have will not protect against the variant. Then just to give you a little bit of a sense of what is this Bloomberg vaccines. So if you go onto the website, you can check this up to date every day. So this was on the 30th of January, the 30th. 24 million in the United States, 8.3 million in the United Kingdom, 3 million in Israel, 2.8 in the UAE, and then all the other countries follow in terms of that. So just vaccine on order. So this is the National Department of Health update. We have details on each one of these, but this is just a summary slide. So I'm not giving you the 8 slides on this. But just to say that the Covishield, the minister explained, 100 million doses arrived at Oliver Tambo on Monday. The additional 500 million doses will come towards the end of February or beginning March latest, but probably the end of February. Then Pfizer, the one I explained to you about, there is 20 million doses on order, and a contract will be signed soon against this 20 million doses. The arrival date is unknown. But then there's also what you might have heard of the COVAX facility. And the COVAX facility is designed to bring in 10% of the South African population. So it's to get to about 12 million doses out of COVAX. Now, COVAX have released some allocation per country, and they have made indications that 117,000 doses with delivery beginning as of possibly middle of February will then start coming into the country. And then AstraZeneca, through a different production manufacturer, which is called SK Bio, that's kind of the European manufacturer, they will also have additional doses, and that could also be mid to late February, subject to firstly both of these, the Pfizer one and there's a whole lot of indemnity regulatory clauses in the contracting that needs to be looked at before contracts can be signed. And then also because the second one still needs WHO emergency use licensing. So all of those things come with indemnity regulatory things, and depending all of them, we should have some of those coming into our system. Then Johnson & Johnson's 9 million doses. The arrival date is unknown, but this is the one where the production company is in the country, all right? So there's an opportunity to access an additional 20 million doses being negotiated because Aspen will be a manufacturer, and they are in PE. So there's current negotiations with them to be able to say that they can possibly cover probably the bulk of the population through local production. The goal is to vaccinate 40 million South Africans. Currently, all of this that I've just given you here covers 25.7 million so far. And obviously, this additional 20 doses, you can just make the calculation, would almost immediately cover the full coverage for all South Africans. So this is what National has provided us. And this is the expected schedule of delivery. So you see the 1 million has arrived. The 500 million is pegged here for March, but it possibly will also be towards the end of Feb. There's this expected Pfizer doses in February sometime. And then you can see, as of all the others, from COVAX, from April, as you can see all the numbers coming in. So big volumes are expected to start flowing probably a little bit earlier. This is conservative numbers. So possibly by about April, big numbers will start coming into the country. And once big numbers come in, is the ability to actually start vaccinating at scale. So just to confirm the allocation so far, Minister Mbombo touched on this. Because you take the first allocation is people that's employed by the Western Cape Department of Health. We have 35,000 employees. We've been given first doses confirmation for our 35,000 employees. And the confirmation is the first dose and the second dose. So when you read 35,000, we will get 35,000 plus 35,000, which will be 70,000 for just the people employed by the health department. Then if you go to the private sector, there's also been an allocation of 58,000 doses, and that's also for the first dose. So that 58 is another 58. So that's almost like 160 doses. So if we take that together, we have currently sufficient doses already confirmed before anything else for more than 90,000 people in this healthcare workers in this province. Now, the issue that the minister is saying that we've got these to confirm, there's a third category that we're working on at the moment. And that third category is the people that fall outside these two. So our update as of this morning, we have submitted an additional 10,245 names. And we are in the process of submitting an additional up to 15 to 20,000 names. So who's there? Those categories that we have submitted now to the National Department. Firstly, 4,000 of those is the City of Cape Town. Then in addition to the City of Cape Town, we are also submitting names for about 3,000 for our community health workers. In addition to that, there's about 4,000 students. In addition to that, there is mortuary workers, and then there is also healthcare workers that work in the education department, the DSD department, and care workers, and then lastly, the traditional healers. So we're working on firming up all of those numbers to submit all of those numbers to the National Department, and then we should get a third confirmation, a confirmation of the third group of first and second doses. Our choice was, and that we've asked, is that when the vaccines gets transported to this province, that it comes to one central point, the Cape Medical Depot, and from the Cape Medical Depot, we will be sub-distributing it to the sites based on usage, readiness, and what people will put in the system at that place. So this is the schedule. Plane landed on the 1st. It was carried off. It's currently in Bloemfontein, and samples are in Bloemfontein, sorry, to be tested. Once that samples is ready and that clearance laboratory clears it, it will then be moved to the warehouse. And from there, it will be taken to various, it will be prepared by BioVac, which is the local company that will be distributing it. And it will then start arriving in the various delivery points. Now, for us, the delivery point between the 9th and 10th is our CMD. And then from the CMD, we will then put in a step to get it to our vaccination sites. So that's the current plan. Just to explain to everybody here, the functional process is the following. Each place where you get vaccinated has to be pre-registered and accredited. So that's all the facilities. Then all the people that's going to do the vaccination has to be also pre-registered and accredited, and they all have to go through training so that they can be accredited before they can do the vaccination. Then the second step is all people that will receive the vaccine has to be registered on what is called a vaccination roll, or something similar to a voter's roll. And each client that will receive the vaccine then will go onto that system and then say, I'm going to self-register. So we preload you on the system. Say, Minister Mbombo, okay, let me use I'm using Dr. Nishad Schroeder now because his name came to me. He works in Tygerberg Hospital. His name will be there because we've pre-registered him. But he will get an app like all of us, and he can then go in and go register himself personally on the system. Once he does that, you will get an SMS notification that the system recognizes him, and the SMS will then tell him his vaccination will be on X day, and when he gets there, somebody will wait for him, and he will be vaccinated. So that means he will get an appointment. When he gets there, consent has to be, so he has to give consent, he can't be forced, and he will get his first dose, he will get an appointment for the second dose, and he will also be issued proof that he had a vaccination, and then he'll come back for his second dose. We also have to track to see that he doesn't have any adverse events, and then that data gets entered onto our system to make sure we capture everything. So where are we now? So we've developed what is called an implementation framework. It will be posted on our website, probably on today or tomorrow. It went to cabinet and 1 or 2 changes were made to it. The 1 million doses did arrive. It's currently for quality assurance. The BioVac will be distributing it to us. We anticipate arrival towards the middle or end of next week. And then in our province, the Cape Medical Depot will then distribute to our sites where vaccination will happen. So we're planning to officially start on the 15th of February with the potential to start earlier if we are ready to do it. This is the groups. So we've updated this in our framework. That we're talking roughly about 133,000 rather than 105,000 for the first phase. But the big thing that the committee must take note of, that 133,000 is for healthcare workers. That's all the people that I've explained to you, the students, community health workers, everybody. The big scale up is for phase 2. When we talk about other essential workers across a range of settings, both public and in the business sector. Then clients in what is called congregate settings, but it's in crowded settings. then people over the age of 60, and then people over the age of 18, but with known comorbidities. Now, in this province, we estimate that to be 2 million people. Now, from 130 to 2 million is a massive scale up. And it's in this where we think where the big logistics will come to bear. So we've already met with the city of Cape Town to explore how we're going to do this in a much more streamlined logistic way. And also the IEC to learn from their experiences, because they do voters' rolls and voting from a logistics perspective. They do that quite often. But we're putting a big planning thing together to be able to say to get over that. Now, can you just imagine we have to then register 2 million people by name and ID number onto this vaccine registration system. In itself, that will be a massive logistic exercise. And to get it accurate and correct and assist everybody to be on the system. Then we need to have enough vaccination sites, plus enough vaccinators, plus all the logistics that you require to be able to provide the vaccination by appointment for people to come in. So we're going to need some mass vaccination sites in that regard as well. And then the last phase is then the balance of the people, which is about 3 million in our province. So we are looking at prioritization in the first phase. So we are looking at giving vaccine doses to everyone, but we are not too prescriptive. The only one you will see right at the last line is when we give pro rata to all the places, that patient-facing healthcare workers will take vaccines first before non-patient facing. So then we build in a little bit of that it's a sequencing of who gets vaccinated, but as the vaccine become available, all healthcare workers will be vaccinated. And we will obviously conclude phase 1 as speedily as possible. This is the master facility list. We have 378 public facilities, 41 private vaccine sites. Curators are the people that will be looking after these facilities in districts to make sure that they got all the things in place. And then the healthcare workers is that list that I said to you, each one had to be on this list per name, per ID number. This is a distribution of the sites across the province, the 378 public sites. And the CMD will then deliver couriers in place, make sure that it gets to everybody. And SAPS and law enforcement has been briefed. And the moment the vaccines arrive in the province, the law enforcement will kick in terms of security of the vaccine stocks. Just a little bit about supply chain. 93 vaccine-friendly fridges are due for delivery this week. Generators have been assessed. There's a lot of portable generators on standby. We have all the consumable orders placed, and we are receiving them as we need them. The PPE is adequate. We've designed a vaccine card. We'll be printing that card tomorrow. Vaccines will be distributed to all the places with consumable vaccine cards, information sheets, everything. And then the training that the minister talked about started yesterday. 1,995 vaccinators have commenced training, and it will be focusing on handling, storage, research, special consideration, product information, data, all aligned to the WHO and the national criteria. It is a 3-hour podcast. There's weekly updates, and then there's information sessions following through on all of that. So we've started the early talk about setting up the phase 2 and phase 3 because of the massive logistics. High volume centers will need to be explored urgently. And that's why the city and IEC becomes involved. And we'll engage with the private sector in terms of pooling the vaccinator capacity to be able to do justice to the volumes that needs to come. Only people that are registered by professional bodies to be able to inject, and this is nursing or enroll nursing assistants, will be vaccinators. And then we're putting all the logistics in place for that massive scale up. So just the next steps, we're finalizing this 33,000 names that's not in the 2 categories, and we're uploading it so that national can confirm it. We're engaging the private sector. We met with business for South Africa, and we'll have a Western Cape team be formalized by Friday. And then we're setting up the logistics for phase 2 and 3. This is a poll that we've had running in our department. It's now got 3,000 people that have entered. And basically it says 20% of people say they won't take the vaccine, but 80% says they will take it, or they're very likely to take it. They just need some more information. So we're doing these information sessions to actually gear up towards this. So we got a communication campaign that's based on giving a reassurance by giving the quality information, by inspiring trust, by sharing openly with people and getting local experts and local trusted people to talk, and then to hear the voices and give honest feedback. There's no stupid question, and it's really to listen to all people's concerns and address it in an empathetic manner. These are the tools. The website has not got all information. We got a very good fact sheet that I think everybody should be aware of. And then we also have now video clips of people talking, and also some video clips on this introduction to all of these things. So in conclusion, we've really passed the second wave. Our local teams are still on alert. We need to adhere to be vigilant not to have new cases. Our healthcare workers have taken tremendous strain, and we've done this intentional process of grieving and healing. And there's a strong focus while we gear up for vaccines, but implementation of vaccines is going to be the key drive against COVID over the next months. Thank you, Chairperson. My apologies for running a little bit over. Thank you.
Thank you very much, Dr. Cloete. Very informative as always. Thank you for preparing that information. Before we go to the Q&A, we're going to continue with the presentation from Treasury. So I'd like to welcome Minister Maynier and his team, who are going to tell us a little bit about planning for funding all of this. So Minister, please be welcome to the committee. Would you like to make some introductory remarks?
Thank you, Chair. I will make some very brief introductory remarks, and then I will hand over to David Savage, the Head of Department in the Treasury. Chair, I mean, we've obviously seen the significant work done by the Department of Health in preparing for the vaccine rollout, which I think in any circumstances is going to be a very challenging exercise. Certainly, I mean, it is, if we look at the vaccine rollout, we think based on a very rough estimate, making certain assumptions, that the vaccine acquisition and rollout could cost as much as 1.7 billion in the Western Cape. And because of that, obviously, costing and finance of the vaccine rollout is a significant priority. In fact, the top priority at Provincial Treasury. But I hope that the committee will accept that in this period, there's still some fairly significant uncertainty about the demand forecasting, the supply forecasting, and of course the finance options. I want to assure the committee that we are in conversation with National Treasury at a technical level, and we are waiting for further information about the financing of the vaccine rollout. But we are, of course, concerned that national government will not allocate sufficient funds for the vaccine rollout in the Western Cape. And so we are looking or exploring all the options available. Of course, reprioritization, mobilizing resources from the private sector, and looking at the utilization of our reserves to support ultimately the vaccine rollout. We will, of course, be in a much better position to furnish the committee with more information once the budget process, which is currently underway, is complete, and of course once both the national budget and the provincial budgets are presented in both in the National Assembly on the one hand and in the Western Cape Provincial Legislature. Through you, Chair, I would like then to hand over to David Savage.
Thanks very much, Minister. Mr. Savage, please proceed. Thank you.
Thank you, Honourable Chair. I'll just confirm that you can see the presentation. Yes, we can. Okay, thanks. Yes, I think Dr. Cloete has done an excellent job of simplifying what is an extremely dynamic and complex environment to navigate. I mean, this is an unparalleled vaccination exercise, and there are a great many uncertainties, as the Minister has alluded to. I thought I should just remind the committee that even as early as the medium-term budget policy statement that was tabled in the legislature in November, we'd indicated that this budget would need to gain greater clarity on the vaccination program, and respond to it appropriately. So, as the Minister has indicated, that's exactly what we have been doing. And in an environment of great uncertainty and change, one is always trying to chisel away at those uncertainties and eliminate those elements that get the answers that you need to be able to take that one step further forward. And that process is very much ongoing on a daily basis. And I think Dr. Cloutier had put up some very, very recent information on supplies, the sourcing of vaccine supply, as well as the dynamics of the actual rollout implementation program. And we're actively engaged with him on that. But we obviously are not just dealing with the vaccination program. It'll be complex enough in its own right. It comes on top of a very confined fiscal environment that we find ourselves in. We're already having to adjust, as we've indicated in the MTBPS, to significant reductions in the equitable share. These are driven around the new national strategy on public sector compensation reductions, but also non-compensation reductions that are being executed, that are having very, very significant effects on our budget, and there are uncertainties there as well, most notably in terms of the wage agreement looking forward, and what that might mean for compensation pressures. As Dr. Cloutier has indicated, we have passed the peak of the second wave. We can't take our eyes off the possibilities of a subsequent resurgence, and that we would need to make sure that our health platform remains prepared for that, even as they gear up for the vaccination rollout program. So there are a number of uncertainties that we are trying to cope with in those environments, around compensation, around the management of the pandemic and the vaccination program, but also pressures that emerge from the real economy and the very, very severe contraction in economic activity and the effect that that's had on firms and households right across the province. And there's some very, very hard discussions and choices, and we are urgently awaiting further certainty from national government on the stability of the current fiscal framework that we are working in. This slide just simply restates what I think the committee would be aware of from the MTBPS, is that we are trying to accommodate reductions in projected transfers to the province of over 25 billion rand over the next 3 years. So that's a very, very challenging environment. In that context, what I will do is I will hand over to my colleague, Dr. Roy Haverman, who has been leading in terms of the costing and fiscal response from the Treasury, to talk through the dimensions of the work that is underway there. But I really must emphasize, this is, as the Minister said, ongoing as both demand and supply parameters change, and we get further details on other budget pressures that we are facing. So we're really in the heat of the budget process at the moment. Over to you, Dr. Haverman.
Thank you very much, HOD. So yes, these are the indicative costs. Obviously, the number of different prices depending on how exactly the vaccines are procured. But these are sort of the indicative costs that it seems the actual vaccine itself will cost. But in terms of the current model, these costs will be covered by national, as I think the HOD of Health indicated, and then the vaccines will be delivered to the Western Cape. So if we go on to the next slide, you can get a sense of what the additional costs that need to be covered in terms of the rollout at a provincial level. Obviously, things like vaccination supplies. This will differ depending on whether they are single dose or dual dose vaccines. As the committee knows, the Johnson & Johnson vaccine is a single dose vaccine, whereas some of the others require 2 doses. We estimate for the single dose vaccine that the cost is about R2.33 just for the vaccine supplies, and about double that for the 2-dose supplies. There are other costs relating to cold chain, for example, around $7.34 per item, etc., etc. So each of these items has to be carefully costed, and we have to also take into account some of the upfront costs depending on the specific methodology that we use for rolling out the vaccines. So if during phase 2 or phase 3 the decision is made to use vaccination centers, then there'll have to be upfront fixed costs that are related to building these vaccination centers. I think the Department of Health in the beginning of COVID did some excellent work in terms of getting Hospitals of Hope up and running under very, very short timelines and using very innovative ways of getting that done. So we have no doubt it can be done. We just need to make sure that there's sufficient budget available. And so at the moment, we're kind of working on an estimate. We've got a task team between us and the Department of Health that the vaccine costs will be in the order of about 231 Rand. For the administration costs related to the vaccine. And so if we have to vaccinate in the order of about 5.1 million people across the public and private sectors, then the costs of the vaccination program are in the order of somewhere between 1.2 and 1.7 billion, as the Minister indicated. If we just go to the next slide, we are working quite closely with the department to look at all the different modalities around how potentially some of the costs can be recovered. So as was indicated by, I think, the Minister of Health, there is obviously the opportunity for us to recover some of those costs from medical aids, and that will reduce the costs going forward. There is, however, I think, as the HOD of Health said, uncertainty on when the Western Cape will receive the vaccines. As Armin's indicated, the funding for the vaccines, but we're in close contact with our national colleagues and our colleagues at Health on that issue. The uptake of the vaccines will vary and have an impact on the demand forecasting. In addition, we are looking very closely at the supply schedule, so we do have a sense of how many vaccines will be coming in and in which month, and so we can allocate sufficient budget for at least the next financial year and then the following financial year on a preliminary basis, depending on if the vaccine program goes a lot quicker than previously anticipated. We may need to make an additional allocation for vaccines in the adjustments budget, but we certainly are open to that possibility. That I think would be a good outcome, because it will mean that many of the costs relating to the vaccination program, rather the vaccination program, is running ahead of schedule. So we're doing some of the phase 3 things earlier than we had previously anticipated. And then I think, as the HOD highlighted, there is continued pressure to fund the COVID-19 response and a need to prepare for the 3rd and 4th wave. It will stretch the system a little bit to have staff having to both do vaccinations and also deal with any obviously 3rd waves. And obviously in the long run, the vaccination program will get rid of the waves. But in the meantime, there may be some cross-cutting issues, and so we are quite aware of that. And when we do table the budget, we have put some thought into how we can fund both the COVID-19 response and the vaccination pressures, because the service delivery pressures remain. And I think, as the HOD of Health has said on a number of occasions before, there are some weird things building under the system, particularly, for example, the delay of elective surgeries. So there may be some additional costs as COVID goes away. So we have to be quite flexible, I think, in our approach to how we deal with the budget. The following slide, this just gives an outline of where we are in the budget. We're we've just finished our engagement with the M2BC, which is the sort of central committee of all the HODs and ministers in the province. And then we will go forward on the process, and we are currently on track for tabling the budget, Chair, as you know, in about a month's time. And I think quite critically, what we really need at the moment in between now and then is more certainty from National on which portion of the costs will be covered by National and which portion will be covered by us. That obviously relates to the operational costs. So now I'll hand back to the HOD for any final remarks.
Thank you, Dr. Haberman. That I think is, we will obviously be able to talk with considerably more certainty and length in the tabling of the final budget. But just to say that we are also very keenly aware of pressures that are being faced by the department in the course of this current financial year as it draws to a close. You know, then if there is a need for additional resources to be placed in the department on an urgent basis within this financial year to support the vaccination, the first phase of the vaccination program, those we will certainly take those steps very rapidly, and so we're not overly concerned about our ability to do that, and obviously in regular touch with the department on their immediate pressures in this financial year as well. Thank you. Chairperson, Minister, I'm not sure if you wanted to make any final comments.
Chair, I think really just to underline the point that I made in my opening remarks. I mean, we are, as the HOD said, in the heat of the budget process. There is significant uncertainty at the moment, particularly in respect of what portion and to what extent the vaccine rollout will be funded by National Treasury. We certainly hope that this uncertainty will be significantly reduced in the coming weeks, and we look forward to providing a more detailed briefing in the future, particularly once the budget has been tabled, which, if I recall correctly, will be on the 10th of March 2021.
Thank you very much, Minister, and to Provincial Treasury. We'll move to some questions, but perhaps we'll see you again once the budget is tabled and we'll get more clarity on some of these questions. We'll now move to our Q&A in our usual fashion, where I'll give each party represented on this committee 3 minutes to pose their questions. You can pose your questions to either the Department of Health or to the Provincial Treasury, and then we'll go down the line and have the responses thereafter. So as usual, I'm going to commence with the DA. Are there any questions for the DA?
Yes, Chairperson.
Thank you, Honourable Philander. Please proceed.
Thank you, Chairperson. Chair, I think the question on many of our lips, when will the first jab be administered in the Western Cape? And then, Chairperson, Dr. Kluter gave us insight into the functional process of the vaccine, as well as into the pathway of the entire vaccination process. So my question would be, these vaccine administration locations, do we have the space, do we have the infrastructure in the Western Cape at this time? Also, it was made mention of fake news. The Unite to Vaccinate initiative by the Western Cape government is hugely welcomed. How does other sectors fit into that initiative? And then, Chairperson, the community healthcare workers has been doing an extremely wonderful job. And how do they receive the news of the vaccine? Are they positive now in their work in the community? And also, Chairperson, my last question for now, who will decide on which types of vaccines each province received? Is that national, or can provinces request on what vaccine they wish to receive? That is my questions for now, Chair.
Thank you, Honourable Philander. There's still just over a minute and a half left. Honourable Bartman.
Thank you, Chair. Chair, my question is to Provincial Treasury. I would like to find out, because in the one slide they said they're going to receive the vaccines from National and they're going to receive the funding from National for the rollout. Now, 231 Rand for associated cost times 5.1 million is about 1.2 billion. And if you only take the AstraZeneca dose times 2 per person for about 5.1 million, which is the cheapest, is about 813 million compared to the Moderna one, which is about 3.8 billion Rand if one had to do that particular calculation. We've heard reports that National is the only one that will be able to buy, but our Premier of the province has also indicated that they're looking to procure separately. How will we be purchasing as a province? And if National is the only one to procure, will they be covering the full cost? Because perhaps he who procures should pay. Thank you so much.
Thank you, Honourable Bartman. I'll then move on to the ANC. Are there any questions from the ANC?
Yes, thank you, Chair.
Thank you, Honourable Windvogel. Please proceed.
Yeah, Chairperson, mine will be to the HOD on slide 5.
Of which department, sorry?
HOD's presentation. Can you hear me, Chair?
Yes.
Yeah.
Of health.
Yeah, yes. Seeing that the peak has passed is really welcome. But however, we need to understand what plans and measures government putting in place to prevent another surge in infection despite the vaccination, as the country is easing down the restrictions. So I just want to know what, except of despite the vaccination, what other plans do they have in place? Then the second one on slide 13, Chair, with the report on the Overberg, particularly on challenges of contract workers. What is the situation like now, and what strategy are in place to handle the situation? And was there any engagement from the department side with the farmers regarding safety protocols in transportation of farm workers to and from work? Chairperson, can you hear me?
Yes, we can hear you.
Yeah. For now, I will park there. Thank you, Chair.
Okay. Thank you, Honourable Windvogel. There's still another just under a minute and a half for the ANC. If you'd like, if anyone else would like to take up the remaining time.
Yes, Chair.
Honourable Lecker, please proceed.
Thank you. Chair, I just want to check, man. Actually, in terms of the storage space for the vaccines once they arrive, do we actually have a proper storage space? And in reflection on what has also been said by Dr. Keith Kuti, was the fact that law enforcement officers will be utilized to secure the place. Now, I want to check, is it only the law enforcement that will be securing that space, or there will be a recruitment of private companies? And how open will that process be if there will be security companies that will be contracted to actually support the law enforcement in that regard? Thank you.
Thank you, Honourable Lecker. I'll then move on to the Good Party. Honourable Heron, do you have any questions?
Yes, thank you, Chair. If I may start with the Department of Health, and to first of all acknowledge the Minister and the HOD for the vaccination implementation plan that was sent to us last week. I think it was dated 21st of January. I thought it was a very thorough and reassuring plan, and I hope it's published for the people of the Western Cape to read, because I think it will give confidence that there is a plan and it's a good plan. I just want to raise a question. The plan and the presentation makes absolutely no reference to the Premier's announcement that the Western Cape will be procuring its own vaccine, or will be looking into procuring its own vaccine. And I'm wondering why that is, and what information we can get about the progress with that plan to procure a vaccine. And then for the Department of, or for the Treasury, there's a 1.7 billion rand cost that the Minister referred to, and I would like to know if that is the cost of the provincial implementation that was portrayed on slide 6, I think it is. Is that what the 1.7 billion is for? And then also similarly to my question to the HOD for Health, there was no reference in this presentation to any provision or any planning for the Western Cape to procure its own vaccine. Thank you.
Thank you, Honourable Heron. And then finally, we'll move to Freedom Front Plus. Honourable Murray, do you have any questions?
Yes, I would certainly like to pose a few questions. I noticed that the Minister has said that Johnson & Johnson is the only pharmaceutical company that will locally produce a vaccine. But I also see that Johnson & Johnson's 9 million doses, but 20,000 from Pfizer. Is it because Johnson & Johnson cannot produce that amount, or is it because of price, or is it because of efficacy? And that's my first question. The second one is, when the department decides first doses will go to the following professions, did they say the same percentage of employed by each profession will receive that amount of doses, same percentage, whether it's 2, 3, 5, or 6%? Or did we play what you call it, he loved me not game? To say, yes, we will give certain specialists, 90% of them will get the dose, 20% of dentists, and 5% of, let's say, medical practitioners. How do they come to that formula? That how many of them will actually be given the first dose? Then I want to say, those vaccines which requires 1 or more doses, say 2 doses, why do you still order from them if it's more expensive? Unless you say it's more easily available, or it's cheaper, or it is more effective than the others. And if they have the same efficacy, why do we even bother to order it from pharmaceutical companies whose product requires more than 1 dose? Then finally, I know my 3 minutes is almost up. If you don't get your budget, and if you don't reach an agreement with the unions on wages, and you will have to cut your budget, in whose favor will you cut budget? Are you going to spend most of the money that you do have on fighting COVID, and are you going to neglect diabetes, or people with kidney problems, or people who suffer from cancer, or people who need urgent operations? Have you made that calculation? Have you come to a decision on that? Because people are not only dying from COVID, more of them are dying because they cannot get renal dialysis. Thank you.
Thank you, Honourable Murray. That then concludes round 1 of the questions. I don't know who'd like to start responding first, Health or Treasury? We have a volunteer. Thank you, Minister. We'll start with you then. Minister Mania. You're on mute. Oh, there we go.
Chairperson, I in fact wasn't volunteering. I was actually switching on my video to do exactly the opposite and say that given that the Department of Health is the lead department in this case, I would think that the Department of Health should kick off.
Okay. All right then. Minister Mbombo or Dr. Kleti, please proceed.
Thank you, Chair. I will respond to some and then I'll skip some for Dr. Klute, or he may add, and some that I will have responded to. In regard to the infrastructure, the combination of the sites, firstly for the phase one, because it's the 35,000, it's our own staff. So it forms part of the occupational health and safety kind of an environment for our staff to be vaccinated. So there will be more use of our own health facilities for the phase one. Phase one for 35,000, it's quite easier compared to, I think our headache will be in the phase two, but already we're having the engagements, for example, with the old mutual that where they are no longer utilizing some of their own areas or sites, especially in the metro. Plus also having conversations with the municipality and all of those. But the point of departure that needs to be prioritized is at a health facility level. In regard to the fake news, unfortunately, it will always be the case when it comes to the fake news for any, not only for the vaccines, but what is worrisome is about when people who are influential, people who are in the leadership positions, where they know that whatever they say out of their mouth, it will have an impact, especially for someone there who doesn't have an access to the scientific research. So it becomes worrisome. Hence, immediately when we hear about that, we often immediately through our website to respond to such. But at the same time, we have to be proactive. Hence, we find that the communications, the packaging of the communication and the messaging that is packed accordingly to the different, customized to the different scenarios and also to the consequences. It's crucial. For example, in my engagement with the traditional health practitioners, you have to use examples that they can understand, for example, on how does the vaccine work in regard to the soldiers, the hamlets and all of those. Same applies. Why is it that it was so quick to manufacture the vaccine, where you have to take them in terms of how you would brew traditional beer umqombothi, where it used to be 7 days, but now because you end up having umlomiso, which is the leftovers of the ingredients in a cup, actually you could be able to share it with the whole of the neighborhood, and then they can make their own umqombothi very faster compared to the time when we have to wait for longer. So we have to customize the whole of this information in terms of their understanding. I think at the time when we were about to do the other phases, or even within these categories, because you asked about the community health workers as well, we have to keep on customizing it. But from the health professionals, you may have seen where the health professionals themselves, they've been at the forefront in terms of declaring that I will vaccinate, which is I'm part of those people that if I meet the criteria, I'll definitely take the vaccine. And then with the issues about note with the community health workers, they are part of the first phase one. But in regard to how we receive the vaccines, we start with the employees of the Department of Health in all the provinces, those who are on PESAL, and then also the private, because they've divided in the 702,000 for the whole of South Africa healthcare workers. There's a 43%, I think, private, and then the other percentage is the public. So you need to understand in regard to, because people keep on asking us, so why are you going for the private without first maybe going for students or other categories or traditional health practitioners? But it's because it's already been embedded as part of the national plan, noting for those who are insured, as I indicated earlier, they'll be charged from their medical aid. So for the PESAL, it also becomes easier, but not only for that, it's because so that they could be able to to give injections to the others. In terms of the type of vaccines, currently, what is coming now, what will be actually vaccinating is going to be the Covishield stroke AstraZeneca stroke University of Oxford vaccine. So, of course, people have got a choice not if they don't want to be vaccinated, but that is where we are. But as you have seen in the presentation with Dr. Klute, where it showed that there will be a COVAX, I think it's going to be in April, March or April, COVAX vaccine, 150,000, and then another 150,000, and then roundabout in May, there's a possibility of the Pfizer, or it could be earlier, because they did indicate that you don't get sure in terms of when exactly. So it means that you will be running these parallel if it so happens that another candidate, another type comes in, but you cannot vaccinate the second dose of a different vaccine to the first dose. So all the people who have been vaccinated with the Covishield, that's why their second dose must be the Covishield. But in parallel, it will be probably when we get the 500,000 to do the second dose for those who have vaccinated now in Feb, that's the time that we might be getting another type. So it will be those that are available. So it's not about, do you want this or do you want that? So it will depend. Take into consideration, making an example for a vaccine that will require minus 70 degrees. Whilst we have got the storage, someone asked about the storage, while we have got the storage, most of the universities, remember they've got the UCT, Stellenbosch, the Red Cross, most of the universities, because they've got this Department of the Biomedical and all of those, they do own their own of their research. So they do have those kind of the temperatures, the research, whether it's for the infertility, where they store all other stuff related to reproduction or whatever. But we do have, for example, you may see, do you have to provide a vaccine that needs minus 70 degrees to Morsfley, for example, or Vredendal, where you find that from the distance from here up to the Vredendal or to Rietsport, it's a 40 degrees temperature. So you have to balance, taking note that after 6 hours out of the fridge, you still, and it's already mixed, those that are being mixed, and that means that you have to discard. Actually, even with a Covishield, because it must be kept between that temperature that is below 8, and then also can be used, but after 6 hours, or if there are left doses where they've already been opened, you have to discard. So you have to balance that. I'm going to use both. Let's say if one vial it has got 10 doses, does it mean that if you have got 4 people, you jab them, and then there are no other 6, and then you find that the whole of that day you are in a situation where you won't be able to do other 6? It means it's going to be a waste. So that's why we have to balance in regard to that space. In regard to the procurement, and also now I'm just putting all together in terms of the contingency plan, which also a member Heron and also member Batman also asked. As we always do, for example, in this kind of the COVID response, there are many of the interventions because it's not only because of the Disaster Management Act, but also in terms of the management of the notifiable medical conditions, of which COVID is part of that, as according to the regulation. So there are many of those that are centralized. For example, the testing from the beginning, where you find that the National Health Laboratory Services is a national competencies with the branches in the provinces. So when the national indicated that there are long queues, where there were times where it has to take us 2 weeks actually to get the results, it meant that as a province, instead of crying, saying that the national, you are responsible for that, so we came up with a different strategy on how we deal with the testing, although it's a national competence. When we had an issue regarding to the oxygen supply, although that the National Treasury was the one that who made this as one service provider to be able to assist the provinces in terms of the procurement for the oxygen. But when there was a weekend where there was a possibility that we are running short of the oxygen, we didn't cry and say that it's your fault. It was us who made the point that something needs to be done, where we call ourselves working together with the officials in the national in terms of negotiating with the private plus also negotiating with the service providers. So what my point that I'm trying to highlight is that with the time that there've been this decentralization, we'll always find a way for us to do things that needs to resolve some of these issues. So you have to have contingency plan no matter what. So with the issue of the vaccination, as you can see that there are shortfalls. Feb gonna get the 1 million, March you're gonna get the 500,000, but there's still a gap because the next one that is guaranteed, according to them, is 150,000 from the COVAX, and then another 150,000 from the COVAX, and then later on in terms of the Pfizer. But again, even in this phase one, because the 1.5 million is it's no longer about the 1.25 million of the healthcare workers in South Africa, as was promised. Now it's about 700, which is half of those, because they must get both doses. Now, what's going to happen to the others who end up not getting a dose because of that shortage? Yet it's about them who have centralized the procurement. People won't be asking, where's the National Health Minister or National Finance Minister? Where's the President? They will be all calling, including in the members in the parliament, Mbombo and whatever, you are failing, you resign, forgetting that we allowed a situation of this monopoly that ended up impacting on us, as we have seen when it comes to the testing, the examples that I made. So that's why the contingency plan for the province, because in terms of the constitution, it's a concurrent function of the health, and also the national, they don't own hospitals, they don't own patients, it's us. They don't own staff, we own the staff. So whilst we commit to make it a point that the national program, as the HOD has presented, but we need to have something just in case, because it very so happened that we end up having the third wave, and then most of the people, especially healthcare workers, I'm still talking about the phase one, are not vaccinated. It's going to be affecting on us. So therefore, the contingency plan is about in the context that this is not happening, but you don't wait until March when the healthcare workers, they don't get vaccinated, or we get a fewer doses, for example, and then we ended up others crying that they don't. So that's why the process now for the acquisition has already started. But with the vaccines, it's not like when you have to the acquisition or the procurement of any other ordinary medicine. For example, a medicine where it's a flour and a sugar and a cinnamon, a baking powder, where it just can be shipped in. But in the case of the vaccine, there are processes in place. Currently in South Africa, the only vaccine that has received the emergency approval is the Provincial. That's the only one, which is the one that has been procured from the SII. So in our context, things that needs to be ironed out, it's about the approval, because you have to legalize things, and also take into consideration that once the vaccines are brought here, it means that the issue of the quality control, where they need to be taken to the National Control Laboratory. And also it's about who was with the manufacturers, the issue of the taking responsibility in terms of the faults and whatever, they put it to the responsibility to the procurer. So at what extent that you absorb that, because currently the national, because they are the procurer, they are covering the whole of the issues of the possible litigation and indemnity and all of those. So one has to consider all of those. So whilst we are making a point that the national program is there, but on sides, we have to make a point that and explore what is possible, take into consideration that all what I've just mentioned in regard to the legal matters that needs to be followed. How spread, how it is restrictions, as I indicated earlier, COVID affects social economy, not only health. So it's no longer a health problem. It's a social problem. It's an economic problem. Now that the churches are open, the restaurants are open, it's not healthy. You're not going to expect a professional, a nurse or whatever, going to a restaurant and ask you, when are you going to put on your mask and all of those. We expect that when you enter there and then you find that there's a whole of the weather bins and whatever, people don't adhere to the health regulations and also the protocols. Any person should be able to take that responsibility and tell those people that where is your mask? So the question about how we're going to ensure to stop the spread, we don't know. We don't know, but what we do, we provide you the information that the issue of the mask, avoiding crowds, avoiding the contact setting of 1.5, avoiding poor ventilated areas, wearing your mask and all of those, staying in your bubble, that's where we could. In other spheres of government, where, for example, they've got environmental health practitioners who could be able to go to Cubana if the clubs are open, and also see to that those sectors, they can even give them the directives or even the penalty. They could be able to do that. But when it comes to whether through ShopRite or Checkers, it shouldn't be Mbombo. There are many people in Checkers. Go and do something. No, there are many people queuing for the disability grant, and the whole of the congestion do something. It should be all other people to have the responsibility. Same applies with the issue of the alcohol, that now it's back. What we know for sure that for the health, we will going to have these issues of the trauma and also interpersonal violence that will absorb. But alcohol is a social issue. So it's supposed to be people there working closely with those dysfunctional families, and everyone else is everybody's responsibility. Storage space, I did mention, remember, like that for minus 70 degrees, which is the ones that need such, like the Pfizer, already has the storage, mostly they're at the universities. For the one that is coming, tomorrow I'm there at our Cape Medical Depot, where we are, as Dr. Casey has presented, that's where when we receive them, that's where it's going to be storage, and then before it goes to the relevant, because we still use district health system as the same way that we did with the PPE, where we use Cape Medical Depot for the medications and others, and then we use also at the time temporarily a Good Hope Center for those others, for the big, huge stock. So we'll be there to make sure that all what is supposed to be required in terms of the cold chain, whether we've got enough big spaces, which we do, because that's where our even child immunizations, where that's where we store them. But all those, but you'll hear that, but the team will be there. You ask also about the safety. It's not all about the law enforcement officers in terms of the SAPs, because each and everyone has got a responsibility, as actually we did when it came at the time for the PPE, in regard to ensuring that nobody comes and break and whatever and steal. So it's going to be a similar thing. I think let's wait for tomorrow, where if people want to join us, it's going to be outside the Cape Medical Depot in town. And then the issue of, I think I remember Aaron asked about how come that there is no budget accommodated when it comes to the vaccine in the presentation. It's the same thing, that we didn't include the ancillaries, the consumables in that space, because you need, so like for example the pack, because we've got the packs for each vaccinator, because I already know, because I underwent training as well. So we've got a pack where you know that how many syringe is it going to be, a 0.5 ml syringe, a 2 whatever kind of a size of a needle, and also it's going to be the box, the cooler box, and the hand gloves and all of those. So it's part of the package, but we didn't include them there. Each and every site will also need an emergency tray to prevent anaphylactic shock or some of the stress response that are related to when the person reacts, the person's immunity reacts to their own, to the vaccine. Member Marais, I think Dr. Casey probably just respond to those, including others that I've left out. Thank you very much.
Thank you, Minister. Thank you, Chairperson. If I can proceed.
Please do.
So I'll go start with Minister, but Member Maria's questions firstly. Johnson & Johnson will produce locally. And if you look at the schedule that I sent in the updated slides, their first production is only in June. So, Minister Marais, it's purely about availability and timing and volume. So obviously, if J&J was presenting and present now and registered now, we would definitely be looking at J&J as a very feasible option. Even Mr. Haverman was saying, Dr. Haverman was saying, if you have to look at the administration, it's cheaper to have one vaccine and not to repeat it. And then also, if you look at the cost, it would obviously be cheaper and better. But you need to understand by June, the landscape for vaccines might have changed completely, and we might have more options, and it would be therefore very important to actually keep that in mind. So it's purely about availability. The issue about how did we determine percentages? There's no percentages ascertained, Member Marais. The allocation is to all Western Cape government employed healthcare workers. There's been no determination made who gets it or who doesn't get it. And then for private sector, it's for all the private sector healthcare workers that's registered by their professional bodies. So that's the two allocations. We told you that there's a third category of community health workers, people working for students, for the city of Cape Town. Once we have that allocation, we'll have a total allocation for the province. We have an expert advisory committee that says to us, if you have more people than doses, there's few principles that you observe. And the principles is of fairness, making sure that people that face the patient get it first, and the ones that doesn't face the patient get it second. But that's the only distinction we've made so far. And then I think your question about budget choices is an important one. I think Dr. Haverman of Treasury raised that. We made it very clear to Treasury, Member Marais, that we have competing needs. The first one is we don't have any resources in the budget allocated to deal with the third or the fourth wave. We don't have any budget allocated as we speak to administer vaccines. We don't have any budget to procure vaccines. But neither do we have shortfall in our current allocations to even do just the basic things that we're doing correctly. So Treasury knows all of that. We've had a very detailed engagement and we're meeting on a weekly basis. And that schedule of getting to understanding what the budget allocation for the department is, it's about rendering non-COVID services, rendering COVID services, vaccinating, and making sure that we get the right choices and balances. So then when we make the budget choices and balances, we balance the needs in relation to what we have in relation to what we have available. This is a few other small matters, Chairperson, if I can come back and just touch on them. Is that okay?
Yes, please do. Yes, please do.
Yeah, so just to remember, Philander, just to say that the first dose we currently have as the 15th of February, but it could be earlier depending on when the vaccines arrive at, but we're planning for the 15th. It's Monday, the 15th of February. Where it will be, how it will be, we will be finalizing that in the next week or so. The functional process you've touched on, Minister's touched on that. The vaccine administration locations, you will see that in the presentation I've just sent you now, the 378 sites for public sector, and you see the 41 sites for private sector. That's the locations where we will be doing vaccination from. And I explained to you that we will have all the capacity to do what we need to do at those places. Then just to Member Windvogel, what she referred to as slide 13 is the previous presentation that I had to update now. That slide 13 had a slide in of last week where there was a reference made in the slide about the update from each of the districts in the daily surveillance huddle. That specific comment had to do with it in the Overberg, like in other districts. There was a challenge with contract farm workers when they travel to the Eastern Cape and come back. The issue was about the traveling and the distance and coming back. And then a requirement for the contract workers to be tested before they leave. So that puts a burden on the healthcare system for testing. That was the issue. It had nothing to do with the status of the contract worker on the farm, and that it had to do with the logistics about contract workers leaving and coming back in relation to that. And there's been close cooperation in Overberg with all the farms to streamline the processes, that people don't come with big buckets of people to a health facility just to say because somebody has to leave, you must now test 35 people because they're leaving the province. Just to come back to just clarify, in relation to what the Minister was saying, Member Heron, the framework that you referred to will be placed on our website, but the framework has been updated and it will be a living document. And the updated version, we will then also forward to this committee. So you will see in the updated version, we've updated the sites, we've updated the numbers, we've updated the additional information that we provided you today as much as we can. And then we've added two specific things in there. The one was because Pfizer vaccine is going to be available, that we talk about that we have this cold storage audit to make sure that we have a provision for that. And we also said that myself, as the HOD, will be reporting back to Cabinet quite regularly by the Minister as part of the overall COVID accountability. And then the third thing that we've added is that in the risk table that you got, there is a risk of us not getting the vaccines. And there is then, in the risk table, the addition is made for the province to consider and explore procuring vaccines in support of the national program, which was actually the issue that you say doesn't appear in that framework. But in the updated framework, it appears in the risk table now. In just the issue about the one other thing is that just for Member Lekker, the NAT joints has asked all the prof joints, which is all the provincial entities, to provide a security update of how the vaccines will be secured in each province. So in this province, SAPS, which coordinates the prof joints, is working with all other law enforcement agencies, and they have their plan to secure the vaccines. So we have no insight into whether SAPS is saying that they are going to outsource and use private companies to help them in that process. And if they so do, it will be within the parameters of how they do their procurement. And we have no insight and control over that process. Thank you, Chairperson.
Thank you very much, Minister and Dr. Klütti. I'll then hand over to Treasury for some of the questions directed your way.
Thank you, Chairperson. There were two questions put to Provincial Treasury from the Honourable Deirdre Bartman in respect of provincial procurement. Obviously, the Minister of Health has touched on provincial procurement. At this stage, we are obviously unsure of the type, the quantity, and of course the cost, therefore, has not been determined. But certainly, provincial procurement, we anticipate, will have to be funded by Provincial Treasury. The second question was from the Honourable Brett Heron. And that was in reference to the estimated cost. We wanted to provide what I called a rough estimate to provide the committee with the some scope on the possible cost of the vaccine acquisition and rollout. The number to which I referred is a consolidated number. It includes the acquisition of the vaccine, assuming that that vaccine was the AstraZeneca vaccine. It includes the estimated high-level cost of the rollout, and of course it assumes that we vaccinate the full population. In other words, that there's 100% uptake of the full population, which is sort of broadly about 5 or 5.1 million. But the purpose was really to provide a rough estimate to provide the committee with a scope of the possible costs of vaccine acquisition and the rollout in the Western Cape. And Dr. Roy Haveman might want to supplement my reply with further particulars. We are, of course, acutely aware after going through the budget process this week of the Department of Health's requirements in respect of the vaccine rollout, and we will ensure in the budget process that the department is fully supported so that it is possible to roll out the vaccine in the Western Cape. Thank you.
Thank you, Minister. Are there further inputs from Treasury? Thank you, Mr. Savage.
Thank you, Chairperson. I won't go on at length, although I think that there's a lot of technical work that is underway. Just on the questions from both Honourable Bartman and Honourable Heron on the cost side, as the Minister said, that's both for acquisition and delivery. And very interestingly, right at the start of our discussions, the Health Department said our rule of thumb is that it's a sort of 50-50 split. And as we've dug much deeper into the actual cost parameters here, that rule of thumb has held up remarkably well. The costs are, however, very dynamic. As HOD Kluti had mentioned, this is a supplier market for vaccines at the moment. That is going to change, and it's likely to start to change quite quickly. And so we need to accommodate that. And of course, as a province, we don't just assume the cost estimates that are given by others. We look at our own historical data on costs obtained for items like consumables, and are able to then build our cost models on that basis. And I think Dr. Kluti ran through quite a few of the cost items, and Minister Mbombo ran through a couple of the cost items that need to be considered. And it's relatively detailed. We do have the historical data, and that's how we're building our cost estimates on non-vaccine items. I would just end on the costs side by saying is that where this does touch the supply chain management system for consumables, for instance, or if there are any direct purchasing of vaccines, that would obviously be subject to the enhanced transparency measures that we already put in place through the procurement disclosure report, and where Department of Health has always been a front runner in providing that information. When it comes to the purchasing, the way this is, vaccine purchasing is not like purchasing pencils, as I'm sure everyone has by now realized. There are a range of issues that need to be considered. So we take a very practical, structured approach into looking at sourcing, what we would call a sourcing strategy that looks at all potential sources of supply. It matches them against demand forecast, and I think Dr. Hardeman spoke to some of those issues as well. And then it looks at the acquisition modality, and so we're looking at multiple acquisition modalities. And the key point is the one that Minister Mbombo made, is that in a complex, mass-scale public sector program like this, one must have contingency arrangements in for all critical risks through the program. And I think you can see those critical risks being addressed not just around sourcing, but in other aspects of the rollout program design. And we can talk to a lot more detail about if we were to go into purchasing, direct purchasing, how that would stay within both clinical and regulatory parameters that are already established, and are themselves also changing with the emergency youth authorizations and so forth. So there's quite a lot of thinking that has already gone into this, and we are chipping away, as I said earlier, at the uncertainties around this.
Thank you very much, Mr. Savage. We do have time for another round of questions. I think we'll limit the question times to a minute per party. So I will start then, as usual, again with the DA. Are there any questions in the second round for the DA?
Yes, Chairperson Ricardo Mackenzie. First question to the Department of Health. Mr. Savage just spoke about contingency measures. I just want to get from the Department of Health, load shedding, theft, vehicle accidents. We know our roads are very notorious. What is the contingency plans in place? And then if someone is recovered from COVID-19 to the DG of Health, do they also have to be vaccinated? And will the Western Cape government's website have ever seen a dashboard like we currently have, or the dashboard we can log into every day at 1? And then how will undocumented individuals be tracked? Because we know that everybody, in order to reach herd immunity, everybody must be vaccinated, but how will they be tracked? if they don't have documentation. Is my minute done, Chair?
You can carry on. You've got a little bit of time left.
Okay. And then the movement of people, I mean, obviously, South Africans being notorious around Easter's coming out in 2 months' time, how will that be managed if Ricardo goes on holiday to Port Elizabeth, for example, and he was due to get the second dose of vaccine? Will he be able to get that vaccine in another province? And then at which point during the vaccine process of the next few months, would we be able to get the vaccines at pharmacies, general spaces, so we don't have to go to one of the 800 venues to get the vaccine? Thank you.
Thank you, Honourable Mackenzie, for your questions. We'll then move to the ANC. I see Honourable Dugmore's hand is up.
Thank you, Chair. Can you hear me?
Yes, we can.
Yeah, I've had to join from my phone. I seem to be having a serious issue with the laptop. But the first thing I would like to ask to MEC Mainir, if he can share with us what practical efforts they have made as per the Premier's statement to procure vaccines for the province. If you can just actually explain, because the Premier did say he's going to do that. So if we could please just have that response from MEC Mainir. Which vaccine suppliers have been engaged by the Premier? What has the response been? And then secondly, to Dr. Kluti, in the first phase, I think one of the sectors that often gets forgotten is the undertaker. I saw there was a reference on the presentation, undertakers. I saw there was a reference to staff working in mortuaries, but the undertakers themselves are a key sector that are, having to work with people who've passed away due to COVID, work with families, etc. And I wondered whether there would be any consideration to the undertaker profession being able to benefit in the first phase. And then just in conclusion, I wanted to say thank you very much for the work being done, the presentations on the delivery strategy, and to just repeat from our side, we think that this shouldn't be seen as a competition. It should be seen as a joint effort between national and provincial. We do look forward to further financial information. And just possibly the head of department, Savage, can confirm, at this point, is there no indication from Treasury nationally? You've worked out, I think the figure from Dr. Haverman was about 231 admin costs. Is there no indication as to what provinces may receive to support the actual delivery of the vaccine as opposed to the cost itself? Thanks.
Thank you, Honourable Dugmore. Are there any questions from the Good Party?
Yes, thank you, Chair. I don't feel like I got a clear answer from the MEC for Health around my first question, so I'm going to repeat it. The Western Cape government announced that it intends to procure its own vaccine. I mean, I'm looking at some of the headlines. It says Western Cape government to go it alone. The Western Cape government says it will buy its own COVID-19 vaccine. So I want to understand why that isn't in the Western Cape plan, why it wasn't presented to us. And if I understand the MEC for Health, she's now saying that this is not the case, but that the intention is only to have as a contingency that if there isn't sufficient supply, then the Western Cape government will explore procuring its own vaccine. Can we get clarity? Is the Western Cape procuring its own vaccine, and what plans are in place to do so? Or is this just a backup plan? Thank you.
Thank you, Honourable Heron. Then finally, the Freedom Front Plus. Are there any questions from you, Honourable Murray?
Yes, thank you, certainly, Chair. Dr. Kluti, I would like to know from you and possibly the Minister, I'm a victim. I brought it up before, and subsequently a lot has happened around that. Even the High Court has ruled that doctors can administer or prescribe this drug to patients who require it if they are seriously ill. Now, it's the cheapest on the market. You can't get a cheaper drug than that. Why don't I hear anything from the department about ivermectin? We don't have money. We think we're going to have budget cuts, but we don't look at the most cheapest and even effective medication for COVID. It's not a vaccine. It's not competing with other vaccines. I have 3 friends now. him, his wife, and his child, and his daughter recovered. And they stay here in Athlone. They recovered within a week from COVID using ivermectin.
Thank you,
I
Honourable
have a lady here staying in Durbanville in Morningstar, colored lady. She and her husband both have contracted this. She had to go to a vet to get this ivermectin. She got it and she's recovered. I would like to know, why don't this deserve a mention in this report, seeing it's a High Court order that they must be allowed to use it?
Thank you, Honourable Marais. That then concludes our question rounds. I'll then hand over to the Department of Health for response, please.
Thank you, Chair. In regard to from Member Mackenzie asked about the contingency related, for example, with the load shedding and all of those. In terms of the package of the requirements for the storage, specifically those where it needs the minus 70 or less, even in minus 80, there should be also that storage that is also goes to the generators. As I made in an example that with the universities already, they are utilizing those for their own research, storing all those molecules or whatever. So it already has the backup in regard to that space. And then in regard to the issue of tracking people, because remember, again, it also requires community buying and support, just like with a child immunization. You immunize a child at birth, and then you say, "Mommy, you must come back at 6 weeks." So, but there's no guarantee that that child of the primary caregiver will bring the child at 6 weeks until up to age 5, 6 weeks, 10 weeks, 6 months, 9 months, and all of those 12 months, 18 months, 3 years, and 5 years. So there's no guarantee that they will come, but you make a point that at the time that the person presents in that first engagement, you provide the person with all of the information, with so much honest and also with so much information, so that you build that trust, so that the person can have a confidence that it will be worthwhile to come back. So that first kind of engagement is crucial. As part of the vaccinator training, one could be able to see in terms of that, because it takes about 5 hours, the first, actually, the whole video, the blog or the podcast of it. It's where it takes you throughout in terms of what is essential about all of those. However, having said that, again, if you look in terms of the programming, you'll be given a date when you're supposed to come back again. Some people don't even come back for family planning. Some people don't even come back for antenatal care. So it's not about that. We are saying that we think that there will be new people, or people will have probably saved up to the level that they could be able to see to they come. But that's why it's important to give that information that we don't know at what is the extent and how long the first dose in terms of the effectiveness lasts. But the date we are giving you is based on the evidence that's where you will need the next second dose. And you must understand that if you don't come, it means that you may not be protected. So some of those kind of information is crucial. Yes, in terms of the tracking, there will be that kind of a dashboard already. The what we call it, the information system that is running through the national is already running, and people already can be able to register their names using their ID. But again, the first ones are the ones who are on PESAL, and they are also healthcare workers. In regard to going holiday and all of those, remember, again, for now, is still the phase 1. Like, in as much as I want to jump the queue, but if I don't meet the criteria of being a healthcare worker, I don't have, for phase 2, I don't have comorbidities, it means that I will have to belong to the phase 3. Phase 3 could be in June or whatever, depending on the availability of the drugs. So that part of it is important. I think they, to answer now, member Haroun about this, as I indicated, that in terms of the contingency plan, the objectives, because I want to read the purpose, because I want to read it as it is. The purpose of this memorandum is to request Cabinet, which is what we submitted, to approve a framework for provincial contingency vaccine acquisition, including procurement strategy to supplement the national procurement acquisition plan as necessary and possible, and guided by the legal opinion provided by the Department of the Premier, the whole of the governments. It also talks about engaging the national, because sometimes normal French might have some connections of the manufacturers, maybe has built relations and networks in the UK or the Premier, whoever, where probably they could be able to fast track, and therefore I could pass that information to the national. Just making an example, I regard that space. As I indicated earlier, you don't want to run two programs, because as I think HOD Savage did indicate in terms of the complexity. The complexity, as I indicated, it's not about saying that I've got a R5, I'm buying, give me 5 or whatever, 20 or 200 of the vials of a vaccine. One, you have to consider in terms of the approval by the SAPRA, and also it must be that there must be a quality control where a sample is independent. The National Control Laboratory is part of the 12 in the world that have been accredited by WHO. It's in Free State. It was part of a partnership with the National Department of Health then, I think 10 or some time years ago, in regard to that space in terms of the testing of the, not only about, because these vaccines are coming all the way. What if it has changed the ingredients of the, we call them adjunct of the vaccine throughout the way? What if what we are buying is not actually what we are getting? It might be just maybe a wrong label and all of those. Plus also they have to use a labeling that suits the context in terms of the South Africa, but it's mostly BioVac who does that, but it has to go through there. So it's not about you can just negotiate and then people say that, okay, I've got vaccines for you, Western Cape, then can we use it? Because it will be illegal to use any if they are not approved. Same applies if they are not national in terms of the control lab. And also in regards to the manufacturer taking responsibility for any adverse events, or even the errors or the faults within the vial. Because, for example, when you are actually conducting the vaccination, you have to read the pamphlet to the vaccinee and also mention the ingredients. If within the ingredients, for example, there's a, let's say, caffeine, there's a sugar, whatever, and then the person might say, I'm allergic to the caffeine. So you have to read part of it, but who takes the responsibility that now that person ended up having some allergies that are within the content of that vial, yet is not mentioned in terms of that leaflet or in that insert. So who takes the responsibility? So it goes beyond. So the issue of the procurement and exchanging money, it might be easier. But for us as health workers, we do have the responsibility to ensure that we provide what we are supposed to provide. Again, it also talks about the issue of the equity, the issue of the access, the issue of the fairness. For example, if the community health workers, although they are not necessarily dealing with the patients per se, they're not dealing with the invasive procedures per se, but they are the ones who go door to door. They might end up engaging with people who are not diagnosed as patients, but also they are exposed. So at what extent that we vaccinate all of the health professionals, both public and private, and then we ended up leaving them behind. Yet these are the people who have been doing the door-to-door, not only delivering the medicines, but also in regard to community screening and testing. So that's where now it factors the issue of the equity. So same applies at the international level. The reason that actually the COVAX came up as part of those countries that form part of it is about the issue where we find that the countries, not only because they've got monies, we are supposed to have monies. If we didn't, maybe it's still many of the monies in South Africa, But the mere fact that they've contributed many monies from their governments in the development of these vaccines, for example, Moderna, where the USA say that, no, I want all the Moderna before you give it to anyone. So they're sitting with many of these vials, if you check into Bloomberg, where they are vaccinating as many, and when they say that US come first. Same applies with the UK or Russia or whoever, or China, same as India, say that India comes first and then the rest, I'm going to give you the rest. So there's already an issue of the inequities and inequalities in the distribution without actually not penalizing or reprimanding those who came late to negotiations. So it starts from that part at the international level. Same applies in Africa. Whilst we might be having 85% of the cases in the whole of Africa, but we do know that there are countries where there is already drug coming to us from Zimbabwe or Malawi and whatever, but at what extent that we can say for all South Africa, we want it for us. And then the others, they don't have it. They don't have because they don't have money. Same applies in the context of South Africa. We have to do the balance. Same applies within the province. We have to do all of those. So in terms of that contingency plan, it's about we cannot, when we own the patients, because if the provincial health is a steward for the whole of other health interventions, be it the private, be it the civil society, whoever rendering their services in the Western Cape, at the end, in terms of the constitution, the provincial health with the MEC as the person who becomes the custodian of the whole total health in the province. So the time when we ended up becoming another Wuhan Cape in the third wave, if we could end up to that, all the fingers will be pointing to us, to me specifically. So therefore, I cannot be sitting and not doing anything and not having a contingency plan. It has to happen. So it is indeed to supplement, but throughout, we're working through in terms of working with the national in that space. But as I indicated earlier, you don't wait until the house is on fire. You start now buying in fire extinguishers and all of those. So that's why the officials, they are busy in terms of engaging. How will be the process? What are the legal parameters? Not only about where will be the cheapest one, but what is it that we can absorb in regard to, as I indicated earlier, currently, in terms of the indemnity and also possible litigation that are related specifically to the faults in the vaccine and all of those. I'm not talking about the immunization errors because of the vaccinator is not applying the correct principles. They are absorbing those. So what is it now between the health and the provincial treasury in terms of the discussions? What are the other additional funding in terms of that space? When I know that I think on the 14th, when we are meeting with the SAPRA, in the SAPRA, what information are they going to provide us? Are they going to say, if we have proved this, we will send to the National Control Laboratory for the QC on your behalf, or must we take it ourselves? So that's where things are. Thank you.
Thank you very much. Dr. Kriti, is there anything further you'd like to add?
Yes, Chairperson. Just to give member Dugmore the undertaking that the undertakers is part of the list of people that I spoke about. 364 names of undertakers have been submitted. And then just to tell member Mackenzie, people that have had COVID before, everybody gets vaccinated, whether you've had COVID or not. So everybody gets vaccinated. And then to member Mare, the issue of ivermectin, as I explained the last time, like with all medications, we have expert advisory committees that are made out of clinical specialists, and their job is to review all the credible evidence that they can lay their hands on to advise us to say that there is emphatic evidence that any medication we use in this country in human beings have got proof that it is safe and it provides the results that you require. Both SAPRA in the release has still said the release for section 25 for individual doctors to advise and get it. But they still mention that they're still worried that there's not enough credible information. There's advisory technical committees that have looked at all the data, and there are many therapeutics, but they will only advise its use once there is very clear clinical trials. And that's the way we've been protecting all people in this country against the use of medication, because we have expert committees that says it is proven to be effective. At this point in time, we take our guidance from the technical and the clinical experts in this country that have guided us to this point to advise us on which medications to use.
Thank you, Dr. Klütti. Any inputs from Treasury to some of the questions that were directed your way?
Thank you, Chairperson. I'll ask the Head of Department just to touch on the practical measures that are being put in place for provincial procurement of the vaccine. And then there was also a question about the allocation of funding from National Treasury. There is, as I understand it, significant uncertainty, but again, I would be grateful if the department would supplement that reply. Thank you.
Thank you, Minister. Chairperson, yes, on the question of the sourcing strategy for the province, I think the question of whether there should be a contingency strategy has been addressed by both of the ministers, and cabinet decisions being taken to that effect, that there does need to be a contingency acquisition strategy. We've talked around the various dimensions of it, and we are in preparations, as I indicated earlier, for procurement. We're not, though, in a formal procurement process at this point. The parts of the elements of a strategy that are worth mentioning here are first around the demand planning. So because of the complexity of what we're trying to accomplish, one has to have clear demand forecasts spread over time relative to the target population, and then to formalize that into a plan that is rate limited by a range of factors. The second is around market analysis, which is looking at the evolution of the supplier market. It's rapidly changing, as we've indicated, and there have been some engagements with suppliers, some unsolicited, that have occurred, and that's why I think the acquisition, the determination of acquisition modalities is very important, so that we're able to effectively circumnavigate unsolicited discussions and put them into a very clear market analysis and market engagement framework. Alongside that, as we've indicated, there's a regulatory analysis underway. There are complex medical regulatory issues, and there are complex financial regulatory issues associated with liability and so forth that are also under assessment. And you might well ask, well, how is this all under assessment? Well, there's a strategic sourcing team that is being pulled together. It's led by the Department of Health, but supported very strongly by the Provincial Treasury in the areas where we have expertise. That is looking at the overall framework, making sure we're making progress on dynamic demand forecasting and the methodology that we're using for that, on the market analysis and the management of engagements going forward. In fact, we've had very many approaches from a range of different sources, including offers of donations, both in cash and kind, to the province that need to be sorted, followed up on, and the credibility of them established as well. And so those processes are all very much underway, and they're necessary before one can formally approach the market in a procurement process that can proceed swiftly, efficiently within the regulatory framework, which is what we, of course, will do. The question that Honourable Dugmore raised around the national contributions, as I'd indicated, we are in detailed technical discussions with national government and National Treasury in particular with this on a very regular basis. We do have a high-level technical meeting on this scheduled for Friday. It was postponed from last week because I think of some uncertainties at the national level. We do understand from these engagements that there will be resources available for the vaccination program as a whole. But we have a number of questions in that. We do not yet know what the share for the provinces will be. You know, if hypothetically there is 1,000 Rand made available for vaccination programs, we already know that about 50% of that would be for non pharmaceutical costs associated with the rollout of the program, but we don't have that split yet from national government. We don't have the overall figure that they have in their budget framework for that yet. And at the same time, we do know already that there are some reductions to our conditional grants in the health sector that are coming through. So we've got to see how that offsets against what additional money may be made available through this through funding for the vaccine program. And then we are still unclear on the modality. Will that be transferred as part of the equitable share of nationally raised revenues to the province, or will it be through a specific purpose, new conditional grant, or will it be added to an existing conditional grant, and if so, with what terms and conditions? So unfortunately, I can't give you more information on that at this point. You know, although we are aware of the broad orders of magnitude that they're talking about, those are really quite rapidly changing and the subject still of technical discussions. So it's really only after Friday that I think we will have a better picture in our mind on that matter.
Thank you very much, Mr. Savage. At this point, I'd like to thank both departments for having presented today. A lot of information that we've received, you know, and a lot of engagement with the two departments. So thank you to the Department of Health and to the Treasury and to the two ministers that joined us today.
Speaker, can I ask you? I was switched off. I unfortunately lost the signal. I didn't get the response to my question about ivermectin.
Okay, you'll be able to watch it on the YouTube channel. It was recorded, so you'll be able to go onto the WCPP live stream and then just rewind a little bit to see the response. All right, so thank you very much to those departments. You may be excused from the meeting, and we look forward to engaging with you again in the future. Members, we have two sets of documents that we need to adopt. The first is the minutes of the 13th of January. I'm going to ask that those be beamed up. There we are. They have been sent to you all. So are there any edits or amendments to page 1? Page 2? Page 3? Right, Honourable Maria, those edits or amendments to the minutes? No, okay. And then final page. If there are no edits or amendments, could I please have a mover and a seconder? Honourable Philander.
Chairperson, moving for adoption.
Thank you. And a seconder, please.
Thank you, Chair. Seconded.
Thank you very much, Honourable Marie. We then move on to the consideration adoption of the committee report for the month of December. You've also received this previously, so we'll just move through it quite quickly. Page 1 and page 2 are the same for all our monthly reports, so we can just continue through to page 3. Okay, any edits or amendments to page 3, page 4, page 5, and page 6. right, if there are no edits or amendments, could we have somebody proposing the report? Honourable Mitchell.
Thank you, Chair. I propose that we adopt the report.
Thank you. Honourable Bartman.
Chair, I second.
Thank you very much. The draft committee report for the month of December is then adopted. I'll then ask members if you do have any recommendations or further questions based on today's meeting, if I could please ask if you would put those in writing by Monday noon, and those will then be sent to the departments. I'd like to thank you all for your participation in this meeting, as well as to the procedural officers who have joined us today and are putting together all the committee documents. We will communicate shortly with the next date for our ad hoc committee meeting. I'm going to then adjourn on this note. Thank you.
Thank you, Chair.